I'm Susanna Proudman. I'm a rheumatologist at the Royal Adelaide Hospital in South Australia and one of the co-chairs of this group. This session will focus on independence, a new domain for assessing remission in rheumatoid arthritis, a very important contextual point to take into account when discussing independence is that we are referring to this in the context of a patient with rheumatoid arthritis considering themselves to be in remission. Thanks everybody for registering and for any questions you may have pre-submitted in the online community forum. We hope that our presentations will address those, but we can come back to them later if needs be. This group is very large, or it was at the time of registration, so the session will take the form of a webinar, and we ask yourself to keep yourself on mute, as I mentioned, throughout the session. Next slide. So we hope you've reviewed the session overview video compiled by one of our fellows, Dr. Thomas Khoo, and the Domain Definition Report for Independence, and maybe even viewed some of the prior publications from this working group on the OMERACT website. The objectives of this session are to review very briefly the prior achievements of the group, present new data on the domain of independence in the context of rheumatoid arthritis remission, comprising a scoping review from Thomas and a detailed body of qualitative work from Caroline, our co-chair, one of our co-chairs. We'll present a draft OMERACT definition of independence in the context of RA remission. We'll have an extended question and answer session with discussion about the work and our conclusions, and finally ask the group to vote on endorsing the draft definition. Once we have a definition, we'll be able to start developing an instrument to measure independence in the context of RA remission, which we think will probably be a multifaceted instrument worth taking into account when having these discussions. The current working group comprises myself, Caroline and Peter Tugwell as co-chairs. We're lucky to have three fabulous young fellows, Thomas Khoo, Emily Barnes from the UK, Gulsum Gazelle from Canada, and two exceptional patient research partners, Winyander Hoogland and Marika Schulte-Volscha, who hopefully we'll get to meet tonight. Next slide. So at OMERACT 2010, the ACR-EULAR remission criteria for rheumatoid arthritis were criticised in some of the discussions. The patient global assessment, which was a patient assessment of their symptoms with rheumatoid arthritis out of a score of 10, was considered insufficient to represent the patient important information about remission. And this was combined with usually a physician derived tender joint count and swollen joint count, and an inflammatory marker such as C-reactive protein. So the patient perspective was thought to be insufficient. So a working group was formed to address this problem. Progress, please. So in phases 1 and 2, 9 focus groups, and also in surveys in phase 2, patients with rheumatoid arthritis reported that 3 domains, pain, fatigue, and independence, were the most important for people with rheumatoid arthritis to consider their disease to be in remission, which we've termed as being as good as gone. And so you can see here the size of the groups of patients who were involved in these studies. Phase 3 involves studying patients over time to see whether these domains made any difference to assessing patients as being in remission, and to look at which instruments work best to measure these. Existing instruments for pain and fatigue were generally optimally valid and feasible, but the results for a new independent scale used for this study, which was a numerical rating scale, which we'll discuss in more detail shortly, were mixed. Next slide. So why are we focusing on independence in the context of RA remission? As mentioned in the earliest focus groups, the term independence was used by patients, so this came from patients themselves. It was ranked in the top 3 most important domains when considering remission in rheumatoid arthritis. And in the prospective validation study of patients in remission, whilst the numerical rating scores for pain and fatigue were optimally valid, etc., but a similar scale for independence was not. So it appears that there exists no ideal instrument for independence currently, and any other potential candidates in the literature appear to focus heavily on physical function. So we felt that we really needed to do further work, first to look at what's been published in the literature about independence in rheumatoid arthritis. So a scoping literature review was performed, and further qualitative work was undertaken to understand the patient perspective of independence in the context of remission in RA in more detail. Next slide. So what do we need from you today? There are more than 110 participants registered for this webinar, and they include principal investigators, patient research partners, carers, providers, product makers, and policymakers. So we're absolutely delighted with the interest in this webinar, and we're keen to hear your thoughts on our scoping review and focus group findings and our proposed collaboratively shaped patient-centred definition of independence in the context of RA remission. And we'll do our best to answer any questions you might have as in the discussion session that will make up the bulk of the meeting. We'll then ask you to vote on endorsing this definition. So we'll commence proceedings now with the first presentation coming from Thomas. He is the OMERACT Fellow for this group, a rheumatologist and a PhD candidate from South Australia, although he is actually speaking to us from the United Kingdom, where he's been performing some of his studies. Over to you, Thomas. Thank you.
Thank you, Professor Proudman. So I'm going to be speaking about the scoping review that this group has performed. We performed this review with the 2 aims of firstly identifying how independence is represented in the rheumatoid arthritis literature, and secondly assessing for any common descriptions or indeed any proposed definitions of independence in rheumatoid arthritis. In order to do this, we had a look at the 3 main databases, Embase, Medline, and PsycInfo. We had relatively generous inclusion criteria in that we wanted to capture as much of the literature as possible, and so the date of publication was unrestricted. We did restrict it to papers that were written in English, and study design was unrestricted, meaning that we also included abstracts, conference proceedings, and full manuscripts. The search strategy was also kept quite open, with rheumatoid arthritis and either independence or autonomy, and the decision to use either of those terms was discussed in this group, given that on briefly reviewing some of the literature, they appeared to be used interchangeably. We restricted it to adult patients with rheumatoid arthritis and specifically looked at use of the terms independence or autonomy as a measure of disease activity, a description of remission, a description relating to a specific activity, or a treatment outcome. We excluded papers which only had a brief or passing reference to independence, including papers that only referenced statistical independence, and we synthesized the data using a thematic analysis with a semantic approach to identify common themes. This is a brief diagram about the process of our scoping review. As you can see, we went through the process of removing duplicates and then excluding abstracts, and depending on the contents, according to that exclusion criteria previously. We also additionally used a snowballing technique to have a look at reference lists from our included papers, and this resulted in a further 4 papers that were included. So overall, there were 58 papers that were extracted by this group with a method of dual extraction to ensure as much accuracy as we could in the extraction of these papers. So there were 58 papers identified, as I mentioned, comprising 43 full articles, 13 abstracts, and 2 OMERACT reports. These included both quantitative, qualitative, and a couple of mixed methods papers. And in terms of the distribution around the world, as you can see, they came from international papers, some of which were multinational collaborations, although notably there are still large areas of the world which have not been represented in the literature thus far regarding independence. 86% of these patients were female. The median age was most commonly 50 to 60 years, although notably there were 3 papers which focused on older persons, defined as more than 65 years of age. And there was very variable disease duration, anywhere from new onset disease to early arthritis, meaning less than 12 months, all the way up to some patients who had had rheumatoid arthritis for 50 years. Notably, we noted that in these papers, independence takes many forms, and it may be present in some situations, but not others. And so it is much more than just the ability to do things physically. It also includes household activities, leisure activities, work and occupation, functions of daily living, and decision-making around healthcare. So I'm going to briefly talk about the 4 main themes that we identified from this scoping review. The first of these was being physically and functionally able, and some quotes which represented this theme were, when discussing independence, patients referred to doing things physically, managing yourself, and that independence would be impossible without, for example, running errands, cleaning the floor, washing clothes, or taking a shower at least once every 2 weeks. And so, as you can imagine, this was the most frequently encountered theme in the literature. However, it almost exclusively focused on basic activities of daily living, rather than complex tasks requiring dexterity or coordination, such as sporting or recreational activities. The second theme identified was a return to a state before arthritis. And some quotes which identify this were, the idea of life being normal prior to disease onset was common, suggesting a parallelism between a status of lost normality and a status of lost independence. Patients with early rheumatoid arthritis ultimately strive to be normal again, literally and figuratively. So this was an interesting theme because it was applied differently in the papers that included an early arthritis cohort compared to patients who had more long-standing rheumatoid arthritis. And we wondered if this was due to the idea that a recollection of normality or a state before arthritis was more immediate for patients with early arthritis and was more of a goal for them. Secondly, it was noted that this is not necessarily specific to independence, and returning to a state before arthritis could as easily be applied to the ideas of pain or fatigue in RA. The next 2 themes were quite unique in that, although they were infrequently represented, they do represent quite interesting ideas. So the third was a sense of freedom without needing to rely on others. Recurring preferences were being able to experience a sense of freedom and being able to live without physical, mental, or social limitations. And independence, freedom, mobility, ability to manage, and not being the prisoner of one's illness. So as I mentioned, although this was infrequently encountered, it was unique in that it did not require patients to have full physical or functional ability to still have a sense of freedom without needing to rely on others. The final theme I'll mention is the idea of having control over the organization of one's life. Having the ability to modify a work schedule aids adjustment. Patients discover they can gain more independence by both acknowledging and accepting help from others. And non-compliance of rheumatoid arthritic patients is behavior that satisfies personal goals, and it should be viewed as an expression of independence and not deviance. And so, again, this was a unique theme in that it captured a cognitive form of independence rather than physical or functional ability. And it suggested that the idea of receiving external help may not necessarily compromise patients' independence and exclude them from being independent if they are able to control these external helps in order to suit their own gains. So the key findings of this review are that independence is not consistently described in the literature, and in fact, there is no definition of independence in the literature thus far. It does take many forms in different contexts, and independence is more than just physical or functional ability, and also includes components of cognition, self-expression, and adaptability. Thank you.
Okay, so shall I jump in? Or
Yes, please do, Caroline.
Okay.
You can introduce yourself.
Hi, so I'm Caroline Flurey. I'm one of the co-chairs from the University of the West of England in Bristol. So following on from Thomas's excellent literature review, we moved on to the qualitative work. So we conducted 5 online focus groups and 1 online interview with a participant who wasn't able to make the focus group dates. We analysed these using reflexive thematic analysis, and that identifies themes that cuts across all of the data. And then we also used directed qualitative content analysis to look at participants' specific answers to these questions. So first we wanted to double check whether independence is the right word for this domain. We were also interested in what participants thought of the patient global assessment and the numerical rating scale that was used in Linda Rush's longitudinal study to measure independence. So we included 19 participants from three continents. The majority were white and female, so we do want to highlight that as a limitation of our sample. So the word independence was used in the initial focus groups back in 2010 by participants, and it was prioritised in the quantitative work, but we still wanted to check that participants were happy with this. So participants did suggest some other words, and I've presented them here in alphabetical order to avoid any value judgments on priority, but I will return later to autonomy in this presentation. But overall, participants were happy with the word independence, which you can see an example of here. So I like it, I do too. Yeah, I don't see anything wrong with it for that word. You know, being able to do what we can when we can, I think it's the best word. So those of you that were at our previous SIG may remember it was suggested that the patient global could be sufficient to capture independence. So I showed this slide to participants and asked them in what ways they consider independence when they're completing it. Participants were generally unimpressed with the patient global, as you can see from this quote, and there was overall agreement that patients aren't considering independence when they're completing the patient global. I don't think I really put independence in my mind when I was ever filling these out. Me neither. No, it was just how well is my disease affecting me at the time. Yep. So it's very physical, and I wasn't particularly thinking about goals or anything I'd be able to do and senses of achievement or anything like that. It was very much, oh, I don't have any swelling today, so that's good, I guess. Yeah, that's how I would be filling it out too. So finally, I showed them this slide, which is the numerical rating scale from the longitudinal study, and asked them what they thought of this for measuring independence in the context of RA remission. And I'll break it down now. So first, the timeline was an issue. There was no agreement on what the timeline should be. And this ranged from a day to months, and some preferred no timeline at all. I was almost thinking more open-ended, like eliminate the week completely. Many participants also wanted a measure of independence to be more specific. So in terms of what they should be able to do to be considered independent in the context of remission, what do we need to help or not need? Participants mostly did like this part, as and when you want, to distinguish independence in the context of remission, because you can still do stuff without assistance, but maybe not when you want to do it or the way you want to do it. And note, I'll come back to this wording of the way you want to do it when I show our definition later. So finally, assistance has clearly been given a lot of importance in this measure because it forms the anchors of the numerical rating scale. So participants had quite a lot to say about this. They questioned whether needing assistance meant that you weren't independent. And they also thought that assistance was too vague because it could mean such a wide range of support. It could mean somebody helping you, or it could be using a walking stick. And I'll come back to assistance in the thematic analysis because it does form one of the themes there. So here's the overview of our thematic analysis, and I'll break this down and talk through it. So at a minimum, independence meant being physically and functionally able. So this means being able to do your activities of daily living when you don't need someone to dress you. It also means being able to meet responsibilities such as work and family roles, being able to go to work a whole day, you're on your feet all day, and being able to do that and then drive home is being independent for me. And also being able to engage in valued activities. I'd measure it in terms of, in the last 6 months, how many social engagements have you had to cancel because of disease activity? For many people, independence in the context of remission went beyond being physically and functionally able, so participation beyond function, so beyond just being present. I was thinking doing your hobbies, but not just getting around to reading a chapter of a book, but maybe even participating in a book club or an online forum, not just your hobbies, but being engaged with your hobbies. It's also having the confidence to make future plans, so not just being physically able to do something, but knowing that that independence can be relied on to last, whether or not I have to start cancelling things. If I get up in the morning and I say I can't do this, then I know I'm no longer in remission. Independence also meant not having to pace or be selective over which activities were prioritised. So this went beyond the independence to do one thing and meant being independent and able to do multiple things. Sometimes you get asked questions about, are you able to go to work? Are you able to complete a day's work? Yes, I am, but then I've got nothing left. So because I need to work to pay my bills, work will be my priority. So I'll go to work. And then when I come home, I perhaps can't stand and cook. Participants also talked about normal or normality, but there was no agreement between participants, or even individuals couldn't necessarily decide on what normal means. So for some, it was a return to pre-RA normality, but others talked about things like irreversible damage, creating a new baseline, or having aged since diagnosis. So they talked about normal in relation to what they thought might be normal for people their own age, but then also acknowledged that between their friends, there was a variation in level of abilities or independence. This participant suggests that what society dictates is what I picture as normal. So can you stand in line at the grocery store? That's something a normal person would do. So participants themselves used the word normal, but weren't necessarily sure of exactly what this means. We also identified a novel concept of cognitive independence, so being free from the cognitive burden of the monitoring and vigilance that comes with managing RA, which one participant described as a mind battle. It meant being independent from the cognitive load of always having to think ahead. Being in remission means I don't have to think about that. I don't have to think about running out of fuel partway through the day. It also means independence from thinking about the management of RA. To me, it means having less life interruptions. When I'm not in remission, I see my doctor more. I have a tendency to get to physical therapy more. I do things that make me focus on RA. And for some participants, it even meant being able to forget about RA completely. For me, it means almost forgetting you've got a disease, so much so that you might forget to take your tablets in the morning because you feel so well. So a complete independence of thoughts of RA. So coming back to the concept of assistance, the meaning of assistance could be subjective and depended on context. So participants may not need assistance because they've adjusted and adapted their lives and their surroundings, but then they questioned whether that would be independence in the context of remission. So I don't need assistance, but I've made all of these adjustments to make sure that I don't. Whether patients consider themselves independent with assistance could also depend on whether they're happy to accept the assistance. So if you want to be in some sort of relationship or partnership with another person, then that's beautiful. You can still be independent and be dependent on them. But if it's something you don't want, or you don't like the person, but you need them to help you, then that would not feel like independence at all. And there's an important distinction in not having a choice but to accept assistance, whilst you might still be independent if you're choosing to accept assistance rather than needing to. I don't want to give up the simple function of opening a jar, but when I'm in remission, I've no problem with that. Could you help that? Could you open that, please? Because I just don't want to, not because I can't do it. So to some participants, assistance was another tool that enabled them to be independent. I sometimes rely on tools to do certain things, not because I'm not independent, it's just easier. I'm sure a lot of people who don't have any conditions still rely on things to do certain things. Whereas for others, true independence meant being completely self-reliant, not reliant on anyone or anything. For me, it's almost literal independence that's remission. I don't need someone else around to help with anything, even opening stuff or in the winter, shoveling snow kind of thing. So even the most physically demanding task to be in remission, you need to be independent for these participants. So finally, independence can mean the ability to make choices and decisions without having to take RA into consideration. So for some participants, this included the freedom to make big life decisions without having to consult their medical team. It's about a degree of personal autonomy that you can make those decisions for yourself, go about your day and carry out those tasks without consulting someone else or asking someone else to come along with you. For some participants, having or taking control meant being independent regardless of RA disease activity. So participants could be stubbornly independent, so battling through to enable them to do the things they wanted. I could still be independent because that's the way I am. I'll battle through it. So I think this is worth flagging because participants may still be independent, but not in the context of RA remission. So it's really important to highlight that simply asking patients, are you independent, may be far too subjective. So here are all the themes together. Underpinning this was the idea that there may be stages of independence, which came from participants. There are stages of independence. First, we've got practically independent. So patients may not have the functional ability, either due to disability or disease activity, but with workarounds and adjustments, in a practical sense, they found ways to do the things that they want to. This level of independence may not meet the cutoff, whatever we decide that might be, for remission, independence in the context of remission. But then disability would also need accounting for as a contextual factor. And it is probably worth highlighting that participants overall did feel confident that they could distinguish between disability and disease activity. Then we have functionally independent, so having the functional ability to do things for themselves. I can get myself dressed, go to the toilet, and so on. For many participants, this was important for a measure of independence, but it may not be sufficient for independence in the context of remission. Then we move on to socially independent. You should be independent to do all the things that you need to do, working, daily activities, social things, fun things, and cognitively independent. You don't think about it because you can do it. Finally, the gold standards seem to be full autonomy, which may be aspirational, and we could probably debate how achievable this is in a healthy population, but this gold standard was owning myself as a social being, giving me the choice to do what I wish to do, and not giving the disease the choice. So in qualitative research, one way we validate our findings is by looking at whether they make sense in the context of what else we know. So mapping these themes to the themes from the systematic literature review, physically and functionally able directly overlaps, and I even pretty much pinched the theme name there. A return to a state before arthritis directly maps to being normal, but what is normal, and also overlaps with some of the concepts of participation beyond function. Having control over the organisation of one's life maps to choices not being dictated by RA, whilst also overlapping with things like worrying about pacing and planning. And then a sense of freedom without needing to rely on others overlaps with the assistance is complicated sub-theme of not being reliant on anyone or anything. So the novel findings from this work is the element of cognitive independence, the complex relationship between independence and assistance, and these potential underpinning stages of independence. So in summary, independence is complex and multifaceted, and we think it's likely we may need a composite measure to capture these different aspects. The qualitative work highlights novel areas of cognitive independence and that assistance is complicated. Whilst participants themselves use the word normal, we wanted to flag that this may be unhelpful in a measure, as there was no agreement on what normal meant. And the word itself is sort of uncomfortable to think of someone as normal or not normal. So the concept may be better captured by its more measurable components, such as abilities. Like assistance, there wasn't a clear agreement on self-management. So for some, it was a tool to being independent, such as making adaptations to enable you to not need assistance. But there also seemed to be a narrative throughout the focus groups that independence in the context of remission meant being able to depart from self-management, such as not having to think about pacing and planning. The finding that there may be stages of independence highlights the need for identifying a clear clinical cutoff for what we consider independence specifically in the context of remission. And there wasn't a clear answer to this from the focus groups. It's also worth flagging that the term autonomy was used to capture the element of independence of making choices and decisions independently of RA, and it may be worth testing this term against independence when we move on to our quantitative work. So our qualitative work has demographic limitations, so we may be missing the voices of some groups of patients, and there may be potential overlap at times with elements of independence being consequences of pain and fatigue, for example, having to cancel plans. But if you remember Professor Kerwin with his blue triangle hat at OMERACT 10, then you may remember the impact triad. So if we apply this to independence, then we would suggest that the impact of independence could be a three-way relationship mediated by the severity of symptoms, which would include pain and fatigue, plus the ability to self-manage these symptoms, and then finally the level of importance of independence or the activity to each patient. So bear in mind the purpose of qualitative work is idea generation and not to reach consensus. Our next steps will be moving to the quantitative work to look at the priorities for what should be included in instrument development and how to treat some of these complex issues such as assistance and self-management. So to finish, in defining independence, I think this quote sums it up really nicely: the freedom to do the things the way you want to do them and when you want to do them, and not be limited and held back because of your pain and your health. So summarising everything together, this is our working definition of independence in the context of RA remission. And the way you want to do it there, we're hoping captures the individual differences of whether assistance or self-management are tools or barriers to independence, which we hope that we can tease out in our subsequent quantitative work. So our definition of independence that we're proposing to take forward to the quantitative work is being able to do what you want, when you want, in the way you want to do it. Thank you very much for listening. And I'll probably stop screen sharing now because it'll be over to all of you for some discussion.
Wonderful. Thank you very much, Caroline. And it's terrific to see so many questions and comments coming up in the chat. So we will hopefully address most, if not all of those. As mentioned, while we're going through this process, for any that arrived a little bit late, we need everyone to stay on mute, please, while we ask the questions, but please continue to post your questions in the chat. But you can also raise your hand using the Zoom function, and we'll keep track of that too. We'll read out the questions and then ask the person who posted each question whether they have anything further they'd like to say, to speak to it, as it were. And then members of the working group will do their best to answer the question. It'd be good if you keep your video on while you're speaking, and remember to mute yourself when you're finished. If everyone else wishes to continue posting comments in the chat about a specific question or raise their hand, please do so, and we can open each question up to the broader group for discussion, asking individuals again to speak to these as we go along. So we've asked Gulsum and Marika to help coordinate this part of the program. We still have more than 50 people on the group, which is not very easy to do in a group discussion. So hence our quite strict rules on this, and needing some guidance from our fellow and patient research partner, Marika. So maybe, Marika, what has stood out to you so far from the questions, and who do we need to ask to make some comments about their question from the chat, please?
Well, I wrote down all the questions. The first one I already answered, but maybe nice if we put it also forward. That's the background of the participants on the call. So the question was asked by Pam: how many patient participants are on the call today with RA? But I think we can look into that afterwards, and we analyze all the stakeholders who are on the call.
Yes, it doesn't appear that we can actually report that today. Be interested to know whether people think it's important that people have RA, or whether they've had RA that's in remission, that much of these concepts may apply to other diseases. So everyone's opinions about this are equally helpful. Any other questions, Marika, that you'd like to address?
Yes, the one that we talked about very, very many times in our groups about normality. And what actually has been asked is that there's no knowledge when you have like established RA. So have you, for example, over 30 years, you cannot remember what normal was. How do we address that? And also the independency might vary with the disease duration, which is almost similar. So if your disease progresses, how do we address normality and independency?
Caroline, would you like to make any comments?
Well, I think normality is a very difficult one. I think, as I said towards the end, I'm not sure whether measuring normality would be, in and of itself, would be helpful. And perhaps we need to look at what makes up, what are the components of what normal or normality means. So things like, you know, what level of ability would we be considering as independence? Or I mean, as you've seen from not just my data but the chat as well, it's what normal means is there's no real agreement on what normal means, and even never mind between participants, but individuals would have almost conversations with themselves of, well, I think that normal would be what's normal for people my own age, and then they would sort of think, but what is normal for people my own age, because all my friends have all different abilities. And so I think normality would be an incredibly difficult concept to capture, because I think it does mean completely different things to different people, and probably at different times as well. So yeah, I don't know if any, or maybe any of our patient partners have any thoughts on that, but I would probably run from reality if I could. I think it's a difficult.
So please put your hand up using the Zoom function if you can, but I do see Sam's raised your hand there.
Yes, I just wanted to comment on normal. As you said, as far as I'm concerned, I wouldn't spend too much time discussing the concept, because it's more or less a linguistic device that has what we call a personal, that has a personal meaning for each individual, and it might be equivalent to acceptable. It might be equivalent to about anything related to the person who uses the word normal. So I think it would be a waste of time to try to elicit and work out a concept, a definition of normality.
I think that's a really helpful perspective.
Pam?
Yeah, I think Sam makes a really valid point, because for many patients who've had their condition over many, many years, their normality has changed constantly. So I've got a new normal, but my new normal is different from my new normal 10 years ago, my new normal 15 years ago. So I think that's a really valid point. It's what my normal is now that's important to me. I'm not going to get back my pre-RA independence, but am I happy with my current independence, my level of independence? No. And why am I not happy with it? They're the kind of things that are more relevant, rather than looking at my friends who are similar age and saying, can I do the things they do? No, it's not going to change because of anything, drugs or operations. But can I get to a content point where I can live the life I need to live with my current treatments, etc. So great point, Pam.
And thank you for following up, Pam. This idea that independence in relation to what one considers normal is very individualized. And there may be specific factors which influence it, that involve stage of disease, age, maybe sex, and cultural factors, which were also raised a couple of times in the chat about presumably this issue, as well as the broader concept of the work that we've presented. So any instrument will need to take into account the fact that for every individual, there may be a new reference point against which they may well define their independence. So we're certainly very aware of that issue. Any comments people will have about that to expand our view on that is certainly very useful. Thank you. Any other comments on this issue about the state of normal, or some other state, if there's another name that we think is better? Let's move on to another question. Wilson, what struck you about
Okay, so I have two great questions in the chat. One from Ihsan, who is a rheumatologist and epidemiologist from Morocco. He says that our patients use the term autonomy instead of independence. I don't know how different it is. And
I actually looked up the dictionary definitions between the two of these because I was fascinated. Participants sort of in the literature, they're often used interchangeably, and I'm sure Thomas will be able to speak to that better than me. But the sort of dictionary definition is that the difference is autonomy is about being able to make choices without, so you haven't got someone telling you what to do. You can make independent choices. So whereas independence is more the physical side, but my understanding is independence would be more of an umbrella term. And then autonomy is more about the being able to do something without somebody telling you what to do. Interestingly, in the context of RA, patients seem to be using it as so there is an element of somebody not telling me what to do because they want to be able to do things without their rheumatology, having to consult the rheumatology team, that sort of thing. But they also seem to be using it in terms of my RA not telling me what to do. So almost sort of humanizing the condition. And so that's where we're wondering if we've sort of more recently been settling on wondering if it's actually worth testing. If we're moving on to the quantitative, do we give some people the word independence and others the word autonomy and see if we're getting different results? But Thomas may want to chip in from the literature. I don't want to force you.
Thank you, Caroline. Look, I agree from the literature's perspective, the terms are almost universally used interchangeably. I will note that the literature that we reviewed was all English, written in English, and so with linguistic diversity, it likely has different meanings, as well as with cultural diversity, even within English-speaking societies. I suspect the terms independence and autonomy are also have subtle differences. There were a couple of papers which did differentiate between independence and autonomy. And in fact, they varied in terms of whether they called one of them the umbrella term or the other. But there was a particular paper from 1988 that I quite liked, which suggests that independence fails to convey the continuing self-determination manifest even when disability is so severe as to compel greater dependence on others, whereas autonomy describes a coming to terms with oneself and one's society and is seen as a societal process rather than an individual attribute, which is a direct quote from the paper. And I think it captures the idea that potentially there are differences between these two terms in terms of relating to others and the context within society and having independence without needing to rely on other people. But that is certainly not well represented in the literature. In general, in the literature, the two terms are used interchangeably. And so I agree with Caroline's point that we may need to once again turn to our patients to determine if there are subtle differences and whether these vary with our language and with culture.
Thank you, Thomas. Gulsum, other questions?
Other question is from Peter Merkel. So he is asking a couple of questions. Are there any available validated definitions or measures of independence out there? If so, are the definitions or instruments generic versus specific to disease health state? Why focus on a state of remission? Given that many patients with rheumatoid arthritis are in low disease activity, isn't independence important there too? If you already explained, then this I missed it out, he says.
Okay.
Do you want me to jump in or do you want to go, Susanna?
So Thomas may want to talk to his findings in the literature because he was looking for measures of independence as well. We haven't published anything on the instruments at this point as we're in the first stage of defining this domain of independence. And we do know that there are generic definitions of or instruments that are used for independence, for example, in neurological diseases. Thomas, would you like to speak to that?
Thank you. So the answer is no. There is no specific definition or tool of independence in the literature for rheumatoid arthritis. There have been tools which have been which include components of independence, or which have been taken from other diseases, which have been applied to patient populations with RA. We know that there are parts of the HAC, for example, as well as the EQ5D and the RAND36, which have components which lend themselves potentially to independence, but none of these are focused tools for the measurement of independence. Regarding the independence NRS, that was the question over the last week. Have you been able to do things as and when you want without needing any kind of assistance between 0 and 10? And I saw that one of the questions in the chat asked why this wasn't valid and or feasible. And I think when it was tested on a large sort of patient population, unlike the other measures of pain and fatigue, it lacked the longitudinal validity that other measures did, and I think that's part of the basis of why this particular group has focused on this idea of independence. But I suppose it lends credence to the work that we are doing at the moment. That at the moment there are very mixed results from the literature, and there are certainly no clear definitions. There are barely even any common descriptions, and there are certainly no valid or applicable tools currently for independence, which is, I suppose, one of the major drives of this working group moving forward.
Thank you. Peter Merkel, you had a follow-up.
Yeah, so that's great. It's a helpful explanation. I think it's more of a methodologic issue for OMERACT, which is we always get into how disease specific. Do we start with disease specificity? Do we look out there what's so-called generic, which I think is not an ideal term. I guess I would say, and this is great. It sounds like you've done that, Thomas, that you've looked beyond. I was thinking also neurologic literature and others, because this concept isn't unique to patients with rheumatoid arthritis, although there may be unique aspects to it for patients with rheumatoid arthritis. And those are two different things. And I would advise, as you consider instruments, or even as you consider putting this work into the broader context, to be informed by what's out there. Well, although it sounds like there's not a lot out there, but to be informed by what's out there. And I wonder where in the pathway of developing such definitions one brings what's out there to inform the conversation. And there's good things to say for both. First, let's see what everybody thinks first, and then bring that in, or start from others. I think I like the way you've done it, but I would consider bringing in whatever concepts there are to at least discuss. And then that, of course, raises the second issue, which is how disease specific will this be, and how is it scalable to other inflammatory arthritides? Is it scalable to other musculoskeletal rheumatic diseases, et cetera? And there's no great answer. I think you're doing groundbreaking work, so it's just a methodological issue. Thank you.
Thank you, Peter. It applies to many of our outcome measures and instruments, domains even. They have to be assessed and perhaps validated in other conditions. But if you start somewhere with one disease, then
Sometimes
at least it works in that, or doesn't, as the case may be. So as the Remission in RA working group, that's the patient perspective working group, that's where we've started.
By the way, why remission? Why only remission for RA? Aren't the same concepts there for low disease?
Well, actually, interesting. Martin DeWitt made a comment in the chat about that, and it was a natural progression from the work that we've been doing that we would continue to look at remission. It's also a recognised disease state that is a bit more dichotomous, in that which makes this work easier when it comes to validating a tool. If it works in a more clear-cut condition, you can then extend into others. It may well equally, if we develop an instrument, it may well work in other disease stages or states in rheumatoid arthritis, as well as other diseases. But it's a complex enough disease as it is. So let's start with something simple.
It's partly why I presented the stages of independence, because it did, as you can imagine, as people talk about it in one context, they also talk about it of, what independence would mean to them, not in remission. So it seemed a shame to capture that data and then not include some of it. So that's where some of those stages of independence started coming in, obviously, as the remission group were focusing on independence in remission, but naturally we've captured some of that extension as well. But yeah, I agree. As I was collecting it, it was a shame in some ways to not just capture the whole of independence in one go. So very much agree with that point.
Martin Bors.
Hi, everyone. So it's the other Martin, not Martin de Wit here, that's talking. And I think I made that comment. I agree with, that everything is really interesting, and this concept deserves a lot of exploration that has not been done before. But the background of this exercise, and I'd like to, urge the group to bring back that focus, or else, risk not finishing the project, is we started with the fact that our remission in RA definition that was published in 2011 was unsatisfactory to patients. So we started a group to explore why that was, and we did a lot of work. And we found out a lot of things. And one of the key things we found out is that patients were talking about independence all the time as a very important factor of their experience of remission. And we found out that there was, the literature wasn't good. It wasn't being measured in any useful way. So in the projects that have been described briefly, we just did a numerical rating scale on independence to get at least a feel for what was going on. So I think the purpose of this exercise is to say, okay, so independence in RA remission apparently is very important to patients. How do we get a grip on that? And the work that's being presented now is really beautiful expansion of, what are these patients talking about when they say, independence is an important part of my remission. And I think we should go from there. And once we have, a good grip on that, then you can go on and expand it to other diseases or low disease activity state or whatever you want, because obviously there's strong relationships and things that will work in other diseases as well. But if you make it too big now, then I worry that you won't get it finished for the purpose that we started it from. Thanks.
Thank you, Martin. Yes, we've certainly been very lucky to be able to build on the fantastic work that you and our predecessors in the group have done before us. So very glad to see you here today. I'd agree with everything that you've said.
Do you want to go to the chat next, or Pam?
Pam, did you have a comment in response to Martin's words?
Yeah, I participated way back when Remission was at ACR, I think 2000, I can't remember, 2005 something. And what struck me then was the difference between what we as patients would consider to be remission and what the drug companies would consider to be remission. Because obviously, if they achieve remission at a higher level than patients, then they're getting great results, but patients may not be able to cope. The importance of that as well is in terms of the kind of welfare benefits and insurance benefits you get in each community. So, for example, if my consultant says I'm in remission and I don't feel as I'm in remission, that doesn't affect my treatment. I'll still get my treatment because the NHS pays for it. In America, I assume, but I might be making great assumptions, if a consultant says you're in remission, who knows whether the drug company, that the insurance would say you're in remission, you don't need your medication and we're not going to pay for it. I don't know. So we have to be aware of how important getting this right for patients is. And as Martin said, getting it right for RA patients. We at OMERACT, we have all patients involved in coming to decisions because we all look at the data, and that's great. But we have to get it right for one group in order for it then to be right for other groups so that they do their robust research as well. But to me, that is essential. It's not a great area. It's an area that's essential for RA patients for lots of reasons. But it's great work. This work is great.
Thank you, Pam. Shall we go back to Marika? What other questions stood out to you in the chat?
Well, I see a lot of patient research partners having the discussion at the end of the chat. But before that, I also saw a question asked about the influence of a third party when we talk about independence, and whether we consider that in our work. So if people might say, well, I think you're not in a remission because of, to an RA patient, I think that's meant by a third party. I'm looking, Cristina Hernandez Diaz asked that question. Have you considered the influence of a third party because you have RA? I don't know if Christina is still on the call, because then we can ask.
Yes,
Caroline, you might have some comments on that. Or
Hi,
Christina,
how
did you
are
want to expand on it first? Christina, would you like to speak to that?
You're muted, Christina.
You're muted
I don't
now,
know.
Christina. Are you there, Christina? You're on mute.
Oh, sorry. Yes, I'm from Mexico. And here in Mexico, we have this cultural issue that your family, your friends, and your belief says you cannot do things because you are sick. So this limitation is quite marked in rheumatoid arthritis patients. They stop doing things because they are sick, because they have rheumatoid arthritis. So I don't know if this cultural influence can make a difficult part of the independence definition, because people just stop doing things because they are sick, not because they cannot do things. So I don't know if you have, if you look for this or you found information related to that.
We might
That's
perhaps
really
ask Thomas to talk to that, because I know he looked at that in the literature. And then Caroline, whether you had a sufficiently broad group to get a sense of cultural factors having an influence on one's perception of remission and independence.
So in terms of the literature, I think we were a bit limited in terms of the diversity, linguistic and cultural diversity in our literature review. There were a few papers which did talk about cultural differences, and it mostly positioned patients within the context of their families and how that is markedly different in different cultures. And so given that predominantly the patients included in the literature review were female patients, the sort of intersection of gender, culture, and family and disease was captured in a few of these papers, and the idea that independence means different things in all of those contexts was an interesting observation. However, given that it was a minority of papers which considered this, although we thought it was interesting that there was definitely cultural diversity and that needs further exploration, it wasn't something that we could analyze closely or develop sub-themes or sort of amendments to the themes that we proposed earlier. So I think it is important, and we lack a complete understanding of it, and further work needs to be done.
Caroline,
I very much agree with sorry, Susanna. I very much agree with Thomas's perspective there, and similarly in the qualitative work, as I presented, we didn't have the cultural diversity that we might have liked, that might have picked up on some of these more cultural aspects. So no, we didn't have any findings that related to sort of other people taking away independence from it sounds more like a caring perspective of sort of, oh, let me do that for you, because what we also didn't have, and I recognize some of these concepts with some of my own separate work with men with rheumatic diseases, and we had sort of very few men in our sample. But one of the things that did come up was this idea, which obviously I can only present so much in the data, and it's sort of captured under the theme of assistance, of everyone needs assistance sometimes, and this idea of sort of codependent relationships did come up, of people doing things for each other, but what's the finding it very hard to tease apart what was support because of rheumatoid arthritis and what was support because we're in a loving relationship and we do things to help each other out, and I do things for her, so she does things for me. So so that came up, of how do I know the difference between assistance because we do things for each other all the time, and assistance because I'm not independent. So that's probably the closest we've got to that concept, but I don't think, and it's something that it's a useful thing to think about actually for taking forward into the quantitative work to make sure that we're not missing that perspective. So thank you for bringing that up.
Yes, I think in the time remaining, it would be good to focus on this concept of assistance and the need for assistance. And in fact, sorry to jump in ahead of our very helpful question organisers, but I did notice that Luis Inez had an interesting comment. Needing assistance involves not only a physical need, but also a mindset, a perception of needing it. So it's all about the subjective view of each patient, which I think is correct for this purpose. Inez, would you like to, or Lou, would you like to speak to that? Louis, are you with us? I think the reason why I thought this was an interesting comment, that more and more I've been, while listening to Caroline talk about the work that she's been doing for so long, this idea of actually needing, the necessity for the assistance seems to be key. If you get assistance and maybe you didn't really need it, then that's probably not so relevant to this issue. But if you, at a minimum, we need to talk about the necessity for assistance. And the other factors we'd like to hear people's opinions about as well is what type of assistance. Is there a difference between the use of tools, for example, versus in-person or person-to-person assistance? Do we have any questions or comments about those two issues? How important is it to specify the need for the assistance, and the type, what types of assistance do we think are relevant here and in what way? Marika, would you like to kick it off as our PRP has been involved in these discussions?
No, but first I want to go back to the comments, because you were asking for Maria, I heard, because I saw also a comment from Ina. Did you say Ina or Maria? I didn't hear you quite well.
It was Louis Inez.
Okay, because I also see a comment of Ina. We are separating our mind, cognitive side, from our physical side. So that may also refer a little bit to what you're saying about. So maybe Ina can also, I'd like to talk, but I'm already in a group, so I would like to hear from other patient research partners as well on the call.
Hi, Marika, and hi, everyone. I'm a Canadian patient research partner, and yes, I think this is getting incredibly complicated in terms of all the various factors that go into independence. And so consequently, I made a comment later on in the chat that says it's the patient that can put it all together. And every time you ask specific questions, you are leaving out other factors, whereas a patient puts in exactly what is important to them in autonomy or independence, and that would then be a vase global, as opposed to a lot of specific questions that may leave out the very things that are happening in a patient's life. I guess that's what the point I wish to make with regards to the whole area that we are discussing, which is incredibly complex. Thank you.
Thank you, Ina. That reflects our daily grappling with this concept, not to overcomplicate it, but also to be able to reflect this truly in a way that's useful for as many patients as possible. Marika, did you want to talk about assistance? There's some further comments in the chat now as well.
Yes, assistance as well, but I also see, I will get back to it when I read out this. This is from Pam, and she says, for in the UK, independence is about physical independence. Autonomy is non-interference over, for example, decisions and finance. And Mary is agreeing with that, and also pointing out that under cultural and geographical differences are really important in this matter. It's very subjective, and it comes back in a lot of comments that subjectivity with regards to geographic and cultural and language, the differences are really important and makes it very confusing here. And if we go back to assistance, it may be the same issue, that we also have a lot of subjectivity for me, but that's very personal. Assistance, I feel independent when I can do my own things without bothering others. And if I have to use a cane, or if I'm on medication, or if I need tools, that's fine. I still consider myself independent. But if you ask somebody else, even in my own country, what he or she will think about independence, you might get a different answer. So it's very personal. And that's the difficulty in this topic, I think, that you keep on collecting subjective answers, even within one country or within one condition. So that's something that we need to take into account, how we're going to address that. And I think that's also one of the main issues for this call, is to collect as many opinions, and maybe somebody has the answer, how we can generalize that. And I think that's really difficult, because that's the challenge that we're talking about here.
Thank you, Marika.
I don't know if it helps though.
So we have a couple of comments in the chat about assistance, which I think reflect this individualized issue in relation to the need for assistance. So Catherine Hill says that with regard to whether there is a difference between instrumental assistance versus person-to-person assistance, I think this is very specific to each individual, which I think reflects what you've said. And Martin Bors has gone slightly in a different direction, but equally valid, which is that I think the issue of assistance could be tackled in the same way as the hack, independence with or without assistance. So we can certainly ask people about what assistance they receive, etc. However, I'd be thinking more about assistive tools than assistance from persons. I cannot envisage someone calling herself independent when she needs assistance in self-care activities and so on, presumably from another person. So there are two slightly different views there, and trying to reconcile those two is certainly a challenge, but I think do reflect the findings from Caroline's qualitative work. Gulson, are there any questions in the chat or comments that stand out to you we haven't covered yet?
Okay, maybe it's similar questions. Where does Hakdai come into this concept? And the other one is, does empowerment fit in at all?
Mm-hmm. Who would like to talk about empowerment? Who asked that question?
And
they'd like to speak to that. What's their understanding of the term empowerment, and perhaps in this context specifically?
Angie,
yeah, that was me. I had just thrown it in there. I think just because of the cultural context, I think there is so much subjectivity there with the cultural context and all. Because yeah, for me, I feel empowerment allows me independence. Feeling that, and not just self-management and that sort of thing, where we know that's more similar with that and all, but just in a cultural context and all, and my personality and characteristics, that sort of thing. It's like, I don't think of independent is more physical for me. And like, yes, the autonomy, okay, I can make my own financial decisions and that sort of thing. But when I'm empowered, I feel independent. I'm making my own decisions, doing things I want to do. Just that's what I was wondering. Just, is it too much, reflective of self-management only and not getting to the independence, or where it really fits in?
Caroline, does empowerment align in any way with cognitive independence?
So it's not. I'll say it's not a word that any of our patients in the focus groups used. I think it's a useful concept to think about. It does it align? I'm not sure really whether it aligns directly with the cognitive. The cognitive side of things was more about not having the sort of mind drain, I suppose, of the always having to think about, always having to think and plan, and that sort of constant keeping RA in your mind in some ways to manage it as best as possible. Empowerment, I suppose, is almost more of an external, so other people, things like, I suppose I associate empowerment with things like shared decision making, and so I wonder whether that would perhaps come under a contextual factor, empowerment, because it's probably a bit dependent on how the people around you, whether that's family or your care team empowering you to feel able to do. I don't know, I might be wrong. I think of empowerment as something that someone else, other people or your circumstances need to empower you. It's hard to, you can't really empower yourself. You can be empowered, but so would that be
I think that's where the cultural like context really comes in and all. Like, I think there's so much subjectivity there.
Yeah, I think it's a really important factor to consider though. So thank you for thank you for raising it. But no, it's not something. I was trying to think if it came through with the quali work even in a subtle way, but I don't really think it's something we've captured actually. I think that is new. Yeah, it's useful.
I think the second question related to the HACDI. I think we've really treated that perhaps as measuring mostly function, and certainly does ask questions about assistive aids. So we've been wanting to look beyond that. It probably aligns most closely with the theme of being functionally and physically able. There have been some additional comments that align with the discussions we've had already. Tools or assistive devices offer a freedom that came up in the data. Freedom allows you the opportunities to live your own life without physical assistance from another human, which I would consider independence, says Ben Horgan. And a few other comments too about whether you can get by with your gadgets and tools or not. And if you can't, then because your disease is too active, then you're not independent. Whereas with the tools, you may well feel that you are independent. Are there any other comments that I've missed, Gulsum or Marika, on the
No, I don't
chat?
think you missed anything, but the only thing that really strikes me here is that there's a difference between cognitive, and we found out that already in our work, between cognitive and physical independence. So I see the physical part might be easier to catch than the cognitive part. So maybe that's a way that we can explore further on, but depending on the comments that we need to analyze.
Well, it's a great way to summarize our discussions. Thank you very much, Marika. It's probably now time that we move on to the polling stage of our SIG. At this point, I think we hand over to Shauna. Hopefully the process is pretty straightforward. A little question will come up on your screen and you just answer the question in a way that most reflects your opinion. So should we hand over to you, Shauna? All right, so now we have a chance to at least get a sense of what type of collaborator group each of us comes from. We don't specifically have RA in that, but we can certainly identify how many patients are patient research partners and carers, and there's a range of other options there. So if everybody could answer this question, reflecting on your experiences and interactions within OMERACT, which collaborator group do you feel you most closely align? Patient research partners and carers, policymakers, principal investigators, providers, product makers, payers and purchasers in the healthcare sector or other.
I wonder, before we go just to the definition vote, I just noticed a comment there from Martin de Witt, which might be helpful to clarify for everybody before we, in case it influences the way people choose to vote. So there's a question from Martin asking, do we expect that the proposed draft definition will help develop a more detailed description of the domain, including different relevant components? We need this more detailed description before we can start looking for adequate instruments. So, so our next step would be moving to the quantitative work, which I think in OMERACT would traditionally be a Delphi, but we're sort of considering whether a Delphi for consensus or a survey for prioritization of what should be taken forward into then selecting instruments. So so that process would help us, for example, identify what sort of assistance we should be looking at, or so this is very much a definition to take into the quantitative work. We're not yet at instrument selection. Does that help? Is that sufficient to answer that question? Which is why it's quite broad and kind of vague, because we're hoping that the quantitative work will tell us what the specifics are.
Yes, Caroline,
Yeah,
thank you for that.
I think that this answers it indeed. Although I'm a little bit skeptic whether the draft, for me, it is so generic that I question a little bit whether it will be helpful to identify the specific components that are specific for inflammatory arthritis. But I agree, if that's the process, I think that's a great way to go. Yeah, thanks, Caroline.
Thank you.
Thank you, Martin. So I think we finished that first question, and here comes the second. In which country are you currently residing? Please share with us to better understand the global diversity of our participants. And this requires actual typing, not just checking a box. So it takes a bit longer to answer those questions, but I guess it's coming very shortly. Have you watched the pre-session overview video and read the materials provided? I guess we'll get an answer to this one. It was a little bit harder with all the different free text responses to question 2. So, oh, I am impressed. How many people do their homework? Thank you very much. That makes it worthwhile, all the time and effort you put into putting those things together. And I'd like to thank Thomas, who did our video for us, and everyone else who contributed. Next question, please. So here is the most important question of the day, relating to the definition. Do you endorse the proposed definition of independence in the context of remission in rheumatoid arthritis as presented, believing it accurately reflects patient experiences and needs and is clinically relevant and feasible for application in medical practice, pending the further definition, the further refinement and specificity, I guess, as discussed by Caroline? And the responses are, yes, I endorse the proposed definition of independence in the context of remission in rheumatoid arthritis as presented. No, I do not endorse the proposed definition of independence in the context of remission in rheumatoid arthritis as presented. Or unsure, I'm uncertain about endorsing the proposed definition of independence in the context of remission in rheumatoid arthritis as presented. So please make your selection and submit your answers. Now biting.
That awkward tense moment.
Anyone got a joke to crack?
Oh.
68% endorse, no, 7% don't, and 24% are unsure. Well, thank you very much for answering that question frankly and honestly, which we can now take forward to the group and make further plans about how to proceed from here. Are there any
question?
Yes, final questions or comments?
So the vote being as such, how does one handle this with number of unsure? You could make the argument that the great majority of people who had an opinion endorse this. And if the people are unsure, are they unsure because of the process, because of what it means to so-called vote in OMERACT? Not sure you want to leave it there. You might hear from some of the unsure and perhaps be able to give people better clarity. I would argue that the unsure are unsure for a reason, and you've received great endorsement for those who have offered an opinion.
We could, I mean, up to Susanna and Carolyn, if you want me to run another, I can do a quick poll of if you voted unsure with a couple of options. Let me know if you'd like to do that.
I guess I'm wondering what the unsure allows people who aren't sure, but I would still say that it's as if an election for whatever, if you don't actually vote for one of the other choices, then whatever happens to the rest of the group is what the decision.
Oh, I see what you're saying. So for us, unsure usually moves to abstain.
Right. That's what I was clarifying.
So then, so then the percentages would be completely different that I can't do
Correct.
off the
That's
top
what
of my head right now.
I think you got an overwhelming endorsement for those who felt they were able to vote. Although it's interesting that you've had some people unsure, and we might learn from why they're unsure.
Can we have a blank field, Shauna, instead of a few options that you can let people type in a short thought why they voted unsure, so we can collect their opinions?
Yeah, I can do that for sure.
Different from a third-party candidate. So I would say congratulations, you got great endorsement.
Thanks, Peter.
Thank you.
And yes, thank you, Shauna. That would be great if you could post one of those questions. And I think probably a free text answer is probably the easiest at this point.
Martin Board has his hand up there.
Yes, Martin, please.
Yeah, thank you. So this probably is the moment where you would wish everybody was in a big room and it could take a break and the committee goes out and reformulates the question in such a way that the number of unsures goes down. And that's not possible in this setting. But I would think some of the people who voted unsure would be voting that because they wait, you just presented this and it's very generic and it's very broad, and if this is going to be the final definition and that's then set in stone, if I vote yes, I'm not going to vote yes. I mean, I like the formulation, but it's nowhere near as concrete as it needs to be before you can start developing an instrument, etc., etc., etc. So if you were to rephrase the question to say, have we done enough work that we can take this definition forward and refine it into something? I mean, the next step you take when you go to the Delphi is make targeted domains that would result in something that you can measure. So maybe you, especially with the latter part of the question, you said so many things that could make people, anxious that if they were voting yes, that nothing could be changed anymore. So if you pull back a little bit from that absolute endorsement that you want, I'm sure everybody's going to give you a resounding yes.
Are you proposing that we have another question after this one? That says
something along the line of, given the work that we've done, do you agree that the current formulation of independence, which you then have to show again because obviously everybody forgot that slide, is sufficient for us to continue the work towards defining targeted domains that would allow us to measure this important concept? How do you like that? I just out of the top of my head.
Let's do it, Shauna. We're not looking for series domains within this. This is a single domain.
I just missed the last piece, Martin. So for us to continue the work toward defining targeted domains,
which will allow us to develop an instrument to measure this important concept. And then I said something about how I thought this up, but I don't think you want to add that to the question.
I'm not sure I can have that many words in a question. I'll put it in the chat as I toss it. And are we doing a yes, no? Or are we doing yes, no, unsure?
Yes, no, unsure.
Okay.
And this is a single domain in and of itself, rather than having a number of domains sitting underneath it. So maybe rather than the word domains,
target domain, say target
the word target subdomains or themes.
Yeah, this is, I mean, this is the broad domain if you want to use the current OMERACT speak. And then from the broad domain, there will be one or more targeted domains that attach themselves to some of the elements that have been described.
And I've just put the draft definition back into the chat. Being able to do what you want, when you want, in the way you want to do it.
Pam, was that your question? Yeah.
Okay, so I just tossed that up. I think I've captured. As I launched it, you guys were saying change the target domain, but it's already in there.
Given the work we've done, given the current definition is the current definition sufficient for us to continue the work toward defining targeted domains, which will allow us to develop an instrument for this concept? So it would be better to say, given the work we've done, is the current definition sufficient for us to continue the work toward defining targeted subdomains?
Yeah, Peter Merkel wrote targeted domains or subdomains.
I don't think we're using subdomain anymore, Dorcas. I think we switched to saying you have a broad domain and you have target domains, and the target domains would be what you call subdomains.
Yeah.
Right.
Correct,
The
Dorcas?
measurable, yes, the measurable domains, the measurable units are your target domains.
Caroline, it might be nice if you can pop up the slide with a different kind of independence in the down. You remember the slide? To have a feeling of those subdomains or the different kind of independence?
You mean the definition or the themes? You mean the?
Yeah, we have different kinds of independences, right? You put it under a slide in the downside of the slide, like cognitive independence.
Oh, the stages of
yes.
I don't know if you can share when I'm launching the poll, but as soon as I pull it, as soon as I stop sharing, you probably can. So I just launched the results.
Excellent.
Yeah. So the good news is that 94% voted yes and 6% were unsure, and none voted voted no. So thank you very much, everybody, for bearing with us as we get towards the end of this process. That has been extremely helpful. That will allow us to move forward. So perhaps in the interest of time, I'll bring this meeting to a close. We've heard some fantastic work from Thomas and Caroline, with fabulous support from the group and from our OMERACT support, Bev, Shauna, Dorcas, who've joined our meetings almost every week, or every month rather. We've heard about the difference between autonomy and independence, maybe, the state of normal, the influence of cultural influences, and the need or otherwise for assistance. And we've had a slightly stuttering vote, but I think we got there in the end. So thank you very much, everybody. And maybe if the people who know a little working group could stay on afterwards, so we could just have a quick chat. Moving forward with our meetings, we will now invite the wider group who've expressed specific interest in being part of this group to join us and help us take it forward. So thank you, everybody.